Hello, everyone. I am Dr. Amber Cann, and I thank you for joining me for this review of acute kidney injury as it relates to drug-induced injury and how we treat it. Some of you may have learned about acute renal failure, and that is the old terminology for what we now refer to as acute kidney injury, or AKI. It's characterized by an abrupt loss of kidney function, retention of urea and nitrogen, and dysregulation of extracellular volume and electrolytes. When we treat it, we want to minimize the insult to the kidney structures, of course, but we also need to maintain blood pressure, maintain fluid volume, and make sure those electrolytes are not going awry. As a patient becomes more acutely ill, the risk of acute kidney injury is higher. So in the community setting, the incidence of AKI is low, but as we move into more sick patients in hospitals and ICU settings, the risk of AKI increases. It's also worth noting that the mortality associated with ICU-acquired AKI is very high. What puts a patient at risk of having an acute kidney injury? Here are some of the items that are on that list of risk factors. Elderly people tend to be more at risk, those over 65 years old. African Americans, people that are in a situation of critical illness or trauma anyway. If they already have chronic kidney disease and their creatinine clearance is below 60. If they have other comorbidities like diabetes, hypertension, BPH, cancer, among others. And if we are administering to them nephrotoxic medications like NSAIDs, ACE inhibitors, and ARBs. You'll notice most of the things on this list are not things that we can alter or not things that we have direct control over. However, it is the nephrotoxic medications that we as clinicians can most modify in preventing AKI. When we're trying to treat and identify causes of AKI, we think about them in three different realms. The prenatal is occurring because there is decreased renal perfusion occurring. The intrinsic AKI is due to a structural damage situation in the kidney. And post-renal AKI is due to obstruction of urine flow outside of the kidney. The kidneys, of course, are part of the larger system that helps the body maintain homeostasis in our fluid regulation, blood pressure, and electrolyte balance. That system doesn't operate at its most efficient level if volume depletion has caused perfusion through the kidney to be decreased. Volume depletion could come from a number of sources, hemorrhage, for instance, severe dehydration, GI losses through vomiting and diarrhea, and through use of diuretics, and that causes renal losses. Patients with lower cardiac output due to heart failure also may have decreased blood volume and therefore lower kidney perfusion. The most common drug-related causes of pre-renal AKI are the NSAIDs, the ACE inhibitors, and the ARBs. Let's take a moment to review the RAAS system. That is a multi-organ system that maintains our blood pressure and hemodynamic balance. RAAS, of course, stands for renin-angiotensin-aldosterone system. The RAAS system is mainly comprised of three hormones: renin, angiotensin II, and aldosterone. And the system is primarily regulated by the rate of renal blood flow. The first stage of the RAAS system is a release of the enzyme renin. It's released from granular cells in the kidney in response to one of three factors. Those three factors are reduced sodium delivery to the distal convoluted tubule, reduced perfusion pressure in the kidney, and the sympathetic stimulation of those special cells via adrenoreceptors. Angiotensinogen is a precursor protein produced by the liver and then cleaved by renin to form angiotensin I. Angiotensin I is then converted to angiotensin II by, you guessed it, angiotensin converting enzyme, or ACE. This conversion occurs mainly in the lungs, where ACE is produced by the vascular endothelial cells. And then angiotensin II exerts its action by binding to various receptors throughout the body. As such, it has lots of different actions at many different target sites. For instance, in the arterioles, it causes vasoconstriction. In the kidney, it stimulates sodium reabsorption. In the sympathetic nervous system, it increases the release of noradrenaline or norepinephrine. In the adrenal cortex, stimulates the release of aldosterone. And in the hypothalamus, it increases the thirst sensation and stimulates the antidiuretic hormone release. The autoregulation of renal blood flow is vital to the homeostatic mechanism that protects the kidney from elevations in arterial pressure that would be transmitted to the glomerular capillaries and cause injury. It allows the kidney to maintain a relatively constant blood flow and a constant glomerular filtration rate, or GFR. And doing that is necessary for clearance of metabolic wastes while we maintain the efficient recovery of filtered electrolytes and nutrients by the renal tubules. Blood flow into the glomerulus is carried by the afferent arteriole. And things that can affect the dilation of that arteriole are prostaglandins, nitric oxide, and kinins. It flows out of the glomerulus through the efferent arteriole. And vasoconstriction of that arteriole is mediated by angiotensin II. This whole system is a feedback loop that auto-regulates the flow through the glomerulus to maintain that homeostatic mechanism. It's crucial to understand that the auto-regulation of this system and the blood flow through the glomerulus protects those delicate vessels in the kidney and prevents them from injury. But we can affect that blood flow both in and out of the glomerulus, and therefore we can induce kidney injury by our actions. The first class of drugs we'll talk about that can cause acute kidney injury are the ACE inhibitors and the ARBs, or as we also call them, angiotensin receptor blockers. I've listed for you on the screen all of the current ACE inhibitors and ARBs on the US market. The older ACE inhibitors are not available in brand anymore, but I listed the old brand names here in those cases, just in case you run across an old reference. It's not uncommon to see a temporary increase in serum creatinine after we begin ACE or ARB therapy. Serum creatinine can increase up to 30%, and it's pretty commonly seen within the first 3 to 5 days of starting an ACE or an ARB. But the homeostatic mechanism as it is usually stabilizes this in 1 to 2 weeks after the initiation of drug therapy. Anytime a patient's serum creatinine increases over 30% or maintains increased over a longer period of time, that may require changing to a different class of drug to treat hypertension or fluid imbalance. When angiotensin I is converted to angiotensin II, it is then available to affect vasoconstriction on the efferent arteriole. When we administer ACEs or ARBs, we interfere with that vasoconstriction. We use ACEs and ARBs to affect blood pressure and fluid balance, and we can see here at the glomerulus is where that is happening. Unfortunately, as we start to interfere with the body's own homeostatic mechanisms for maintaining that fluid and blood pressure balance, we can cause AKI. In fact, 20 to 25% of hospitalized patients with CHF will develop AKI within weeks of starting an ACE inhibitor. So we already have patients who are compromised in their kidney perfusion through CHF, and when we add an ACE inhibitor, we are affecting that system even more. Unfortunately, this is a reality of using ACE inhibitors. They are definitely to be used with caution in patients with symptoms of CHF. The other major class of drugs that can cause AKI are the NSAIDs, non-steroidal anti-inflammatory drugs. About 1 to 5% of NSAID users experience some adverse renal event while they're taking the medications. You may recall that prostaglandins play a role in the pain and inflammation response in the human body. They also play a role in the afferent arterial ability to vasodilate. When we administer NSAIDs, we inhibit the activity of cyclooxygenase 1 and cyclooxygenase 2, and we prevent the formation of those prostaglandins. If we are preventing prostaglandins from being formed, then we are affecting the vasodilation capability of the afferent arteriole in the glomerulus. So you can see here, if we are causing less vasodilation in the afferent arteriole by administering NSAIDs, then we are affecting the other side of the glomerulus, and we are changing the hemostatic balance yet again. So you may be able to predict that administering NSAIDs along with an ACE or an ARB can severely restrict the blood flow both in and out of the glomerulus, resulting in major damage to those tiny vessels in the glomerulus. Therefore, it is strongly discouraged to ever administer an NSAID alongside an ACE or an ARB. Now, we know that high-risk patients for AKI do have situations where they do require NSAIDs. So how can we best manage and minimize the damage that can be caused to the kidneys using NSAIDs in these patients? Well, first is to recognize high-risk patients and then start with the lowest possible dose and titrate up very slowly. They should not be used for any duration longer than they have to, and whenever possible, we should use alternative agents. The second realm of AKI is the intrinsic acute kidney injury. It mainly results from a vascular issue like a thromboemboli in the renal vessels or inflammation in the smaller renal vessels that lead to a thrombus or an infarction. The most common type of intrinsic AKI is acute tubular necrosis. It results from a prolonged period of hypoperfusion to the kidney. There's a lot of drugs that can cause this. Among them are the aminoglycosides, amphotericin, vancomycin, and certain contrast dyes. When the kidney vasculature receives very little blood flow for a period of time, the tissues start to die. Fanconi syndrome is another type of intrinsic AKI. It's a rare disorder of the kidney tubules that results in excess amounts of glucose, bicarb, phosphates, uric acid, potassium, and amino acids to be excreted in the urine. Normally, they are reabsorbed through the tubules before the urine is excreted. However, in Fanconi syndrome, this normal process doesn't happen. The most common drug cause of Fanconi syndrome is an HIV medication called tenofovir. The real consequences of Fanconi syndrome aren't in the injury to the kidney itself per se, but the sequelae of wasting those elements like phosphate, amino acids, glucose, and bicarb into the urine. It's also worth mentioning that we can induce a Fanconi-like syndrome when a patient takes outdated tetracycline antibiotics. The tetracycline metabolites can cause renal tubular disease with electrolyte imbalance and induce tubular damage within about 2 to 8 days after beginning treatment. Reversal of Fanconi syndrome can take up to a year. Another type of intrinsic AKI is acute interstitial nephritis. This is a renal lesion that typically causes a decline in renal function. It's characterized by an inflammatory infiltrate in the kidney interstitium. The most common cause of acute interstitial nephritis, drug-induced injury. However, it can be caused in some cases by autoimmune disorders like lupus, Sjogren's syndrome, or sarcoidosis. The most common drug causes, penicillin and cephalosporins, both beta-lactam antibiotics. The least amount of cases of AKI are the post-renal realm of cases. They account for less than 5% of all AKI. They result from some sort of obstruction of urine flow downstream from the kidney. When urine accumulates above these obstructions, it increases the pressure upstream and causes a decline in net GFR. The most common cause of post-renal AKI, kidney stones. Some kidney stones result from natural processes, but we do have some drugs that are known to cause kidney stones. I've listed them here, and they are indinavir,
acyclovir, and probably the most common, sulfamethoxazole trimethoprim, also known as Bactrim or Septra. That's an antibiotic used to treat UTIs. SMX-TMP can cause painful kidney stone symptoms, and patients should always be advised to drink every dose with a full glass of water to remain hydrated. So how do we make adjustments to drugs that are renally eliminated when we know a patient has less than ideal renal function? That comes in the form of renal dose adjustments. When you're assessing a patient and you realize that they may be at risk for kidney damage or they have chronic kidney dysfunction, you'll need to create a stepwise approach to renally dosing medications that they're on. So the first thing to do is gather patient information, and based on that information, you estimate their GFR and creatinine clearance. Next, you'll review their current medications and determine which ones are required to be renally dosed. And then you'll create an individual treatment plan based on those recommendations of lower doses in most cases for medications affected by acute renal injury. And then, of course, after you make those changes, you'll continue to monitor the patient and revise your plan as needed. The most widely used tool we have for estimating kidney function is Cough-Galt equation. It gives us creatinine clearance in mils per minute. This equation does account for gender. Creatinine is a byproduct of muscle turnover. Since most females have typically lower body muscle mass than males, this equation accounts for that and reduces the number that you get at the end of the equation. We multiply the product of the equation by 0.85 in the case of female patients. The Cough-Galt is what the FDA uses for approving most drug labeling in renal dosing. So it is a very common equation, and I highly recommend that you memorize it. One of the major failings of this equation is how we care for transgender patients. This equation assumes a bilateral assignment of gender, and as a result, we don't have a good way to account for patients who don't fit into the binary male-female dichotomy. Another tool you may see that uses another method is called the MDRD. That stands for Modification of Diet in Renal Disease. It is something that gives us an estimated GFR, glomerular filtration rate, based on normalized body surface area. It's more accurate than the Cough-Galt, and it does account for race, so it's often used in staging of chronic kidney disease. The Salazar-Corcoran equation is used to measure creatinine clearance in obese patients, and that's when BMI is over 30 kilograms per meter squared. There are no commonly used drugs that require a dosage adjustment when creatinine clearance is below 90 mils per minute. The general cutoff you'll see is around the 60 milliliters per minute or below. We have several options for how we can individualize the regimen of renally dosed drugs. One thing is the obvious, decrease the dose. But we can also increase the interval that the medication is given. We can administer a loading dose and then subsequent lower doses. We can dose a medication that is removed by dialysis after dialysis occurs. We can obviously switch to another drug that doesn't require renal dosing, or we can put medications that are problematic on hold until renal function stabilizes. The databases of drugs that most clinicians use, the ones that are on apps and on the internet and on your phone, they often will give you good recommendations for renally dosing drugs. I recommend that whatever database that you use for drug information, you get comfortable with finding quickly the recommendations that those monographs have for adjusting doses based on renal function. Here's another tool you might find useful. This is from the University of Louisville. They have a kidney disease program, and one of the links there is an adult drug book that provides you with some renal dosing information. So let's do a few cases to solidify what we've learned. You're rounding on patients in your hospital and you see a male patient with the following orders from the emergency department. Metoclopramide 10 milligrams POQ6H for diabetic gastroparesis. Morphine 2 milligrams IV Q2 hours PRN pain. Famotidine 40 milligrams POQ day for gastric ulcer. And levofloxacin 750 milligrams IV daily for an intra-abdominal infection. The patient's 45 years old. He is 5 feet 8 in height. He weighs 155 pounds, and his most recent serum creatinine is 2.2 milligrams per deciliter. So, based on the stepwise approach, what do you recommend for dose adjustments, if any, for this patient? If you calculate his creatinine clearance based on his patient characteristics, you will come up with a number of 42 mils per minute. Then, consulting a drug database, you will find that 3 of 4 of his medications do require renal dosing. The metoclopramide is recommended to be 50% of the usual dose when creatinine clearance is between 10 and 60 mils per minute. So in this case, we would alter the drug dose order to say 5 milligrams PO every 6 hours. The famotidine is another medication that requires renal dosing. The recommendation there in the drug monograph is when creatinine clearance is between 30 and 60, the max dose per day should be 20 milligrams, or you can modify that to a 40 milligram dose every other day. So we would alter the orders on the famotidine to either 20 milligrams POQ 24 hours or 40 milligrams POQ 48. The levofloxacin is the third medication that requires renal dosing. The recommendations there are when creatinine clearance is between 20 and 50, the dosage should be 750 milligrams Q 48 hours. The morphine doesn't require dose adjustment, so we will leave those orders as written. Okay, on to patient number 2. This is a patient who is a 62-year-old white female with non-insulin dependent diabetes. She's in the clinic today for a 3-month follow-up. She's been taking metformin 1 gram BID and linagliptin 5 milligrams daily. The computer system in our hospital suggests that her estimated GFR is 50 mils per minute per meter square. We have some information from our computer system there on this patient. Based on this information, are there any recommendations for dose adjustments on her 2 medications? When you calculate the creatinine clearance for this patient, you will find that her creatinine clearance is 29 mils per minute. When you look up metformin in a drug database, you'll find something odd here. It has some recommendations not based on creatinine clearance, but based on estimated GFR. Some medications have recommendations in this form, but most of the databases that you'll consult make recommendations based on creatinine clearance. So just be aware that both of those are possibilities. In this case, metformin is recommended to be dosed at a different dose than what we see in the patient. If the eGFR is between 30 and 45, the drug database suggests that the max dose should be 500 milligrams BID and still with close monitoring. So in this patient, we need to lower her dose by 50%. The drug database I consulted for the linagliptin suggested no adjustment is needed for renal dosing in this patient. So we'll just change up the metformin, lower her dose by 50%, and send her on her way. In order to deal with the consequences of acute kidney injury, we really need to determine the etiology. And we do that through a number of ways. First, a detailed patient history is always important. A second option is to measure the fractional excretion of sodium. That really just takes the measured amount of sodium excreted in the urine and compare that to the amount of sodium in the blood. A next option is looking at the BUN to serum creatinine ratio. Both the BUN and serum creatinine are freely filtered at the glomerulus, but urea reabsorption occurs with the reabsorption of water. Creatinine has a negligible reabsorption. So what we see with pre-renal AKI, generally that ratio is 20 to 1 or above. With intrinsic AKI and post-renal AKI, that ratio is less than 20-1. We can look at a urinalysis and specifically the specific gravity, osmolality, proteins, etc., to indicate what type of AKI has occurred. And then finally, a renal biopsy is an option, but it's rarely performed due to the risk of bleeding. It's usually only done when all the other cases are ruled out. There are several organizations that publish guidelines on treating kidney diseases and acute kidney injury. The main guidelines I see used are these three listed here. The primary one is KDIGO, or Kidney Disease Improving Global Outcomes. The next one is AKIN, or Acute Kidney Injury Network. And finally, RIFLE is Risk, Injury, Failure, Loss of Kidney Function, and End-Stage Renal Disease. Those three can be calculated. In general, we have several ways to prevent AKI. The primary of which, from a clinician standpoint, is to avoid nephrotoxic agents when we possibly can and use alternatives when they're available. We can adjust renally eliminated medications to the lowest possible dose and use guidelines to guide us there. If we're administering a nephrotoxic agent, we can use IV hydration prior to that administration. Usually normal saline is preferred for that case. And fourth, we can infuse those nephrotoxic agents that are necessary at a very slow rate. To treat cases of pre-renal AKI, we want to correct the hypoperfusion. So generally we will give IV infusions of normal saline or D5W, dextrose 5% in water, and maintain a target urine output of about 0.5 milliliters per kilogram per hour. We do need to use with caution any fluids that contain potassium, specifically potassium chloride premix solutions and lactated ringers. For those cases of intrinsic acute kidney injury, we want to correct electrolyte imbalances and hypervolemia. To correct the hypovolemia in particular, we use loop diuretics. IV route is preferred, but we can give them orally as well. If you have a patient with severely limited renal function, when the creatinine clearance is below 30 mL per minute, there is a thiazide diuretic that is able to be used still. That is metolazone or Zeroxylin brand name. If the loop diuretics are not adequately correcting hypervolemia, we can add a thiazide diuretic to the loop if necessary. For those cases of post-renal AKI, specifically something related to an obstruction, we want to remind the patient to drink 2 liters a day at least of water to be well hydrated. If it's a kidney stone, we can manage the pain with NSAIDs or opioids. Thiazide diuretics can be used prophylactically for preventing calcium kidney stones, and if the kidney stones tend to be related to uric acid buildup, we can use allopurinol as a prophylactic. This has been a review of AKI, acute kidney injury, how we as clinicians deal with it in dosing patients on medications, and how we cause it, and how we can prevent it. Thank you so much for joining me. My name is Dr. Amber Cann.